Kaushik.
Thank you, Dr. Amal Kumar Banerjee, sir, our past Dean, API headquarters. Now, Nilanjan is very close to me, almost few decades. He was my junior colleague in medical college. Now he's the professor of professor and head of the Department of Endocrinology, NRS Medical College, Kolkata. He is now in the post of Honorary Secretary General, ESI, Endocrine Society of West Bengal chapter. Previously, he was the secretary from 2009 to 2013, Diabetic Association of India. After that, he was holding the post of Vice President of Diabetic Association of India from 2013 to 2021. Is a very dynamic academic personality in West Bengal and is very enthusiastic about the endocrine and diabetic management in different positions, as well as a head of the department of NRS Medical College of the Endocrinology Department. So with this few introduction, may I request Nilanjan to start the proceedings, subsequent proceedings. Thank you, Nilanjan.
So I thank API West Bengal chapter for organizing these master classes and involving me in one such on a very interesting topic of hypercalcemia. Students, you must be knowing that in your general medicine practice, as well as in surgical practice, you do come across acute episodes of hypercalcemia. Acute hypercalcemia is a medical emergency which you need to address, because that may be a life-threatening condition if missed and is not untreated. And whereas chronic hypercalcemia is concerned, we need to go through a stepwise approach to find out, uncover the cause and appropriately treat, because as you will see from the foregoing lecture, that many cases of hypercalcemia are eminently treatable, and not only treatable, eminently curable. Now, to take us through this, we have a brilliant speaker, a young endocrinologist in Dr. Soumik Goswami, who is actually working as a faculty in the same department of NRS Medical College where I am working since long now. And he is also currently the treasurer of Endocrine Society of Bengal and is a member of many other professional bodies, is a very avid reader and a very good teacher also. I think so. Students, you will be taking this opportunity of interacting with Soumik sir on a very interesting topic of hypercalcemia. So over to you, Dr. Soumik Goswami.
Thank you, Professor Sengupta, for that very kind introduction, and thank you, API West Bengal, for inviting me to be a part of today's lecture and today's discussion. Now, when we talk of calcium, the first thing that possibly comes to our mind is the skeleton, the human skeleton. And if you look at evolutionary biology, skeleton played a very important role in organisms exploiting new habitats, in us moving from our marine habitat to a terrestrial habitat. And it played a big role in what we are today. However, if we look at evolutionary biology, calcium, cytosolic calcium, calcium pumps, calcium channels, they are there for even longer. They are there in the most primitive of cells. And interestingly, the intracellular calcium concentration is 10 to 20,000 times lower than the extracellular calcium concentration. So naturally, when faced with high calcium levels, if the intracellular calcium levels increase, they can lead to DNA denaturation and even cell death. However, the hypercalcemia that we face is usually not that severe. It's more of a milder variety. And today, with the use of routine chemistry analyzers, we are picking up more hypercalcemia because of routine performance of serum calcium along with a battery of other tests. Now, when we talk of hypercalcemia, we need to know about how frequently we might face hypercalcemia. So statistics reveal that 1 out of 1,000 patients attending the OPD of a hospital might have hypercalcemia. So if you look at the huge number of patients who attend our hospitals daily, the number is still pretty big. And if you look at inpatients, about 0.5 to 0.6% of inpatients might have a hypercalcemia, for which you might get a referral to a physician or to an endocrinologist. To take today's discussion forward, I'll be dealing first with basic physiology of calcium metabolism. I'll be telling you how to identify true hypercalcemia and differentiate it from pseudo-hypercalcemia or pseudo-normocalcemia. I'll be touching upon the causes of hypercalcemia, their common clinical presentations, which will help us find a diagnostic approach to find out the etiology of hypercalcemia. And I'll be ending looking at the basic principles of management of hypercalcemia, severe as well as mild moderate hypercalcemia. Now, if you look at calcium metabolism, there are three main players which influence calcium homeostasis: PTH, active vitamin D, and calcitonin. So if you look at this image, and if you begin from the center of this image, I'll take the pointer to help you. Okay, if you begin from the center of this image, in response to a decrease in calcium level for any reason, there's an increase in parathormone release from the parathyroid glands. Now, the parathyroid glands have CASR, or calcium sensing receptors. So if the calcium sensing receptors sense that calcium levels are coming down, they release parathormone. Now, what does parathormone do? It acts at the bone to increase resorption of calcium with the aim of normalizing calcium level, and it acts at the kidneys to increase the reabsorption of calcium from the renal tubules to normalize serum calcium levels. These two are the direct effects of parathormone. It has an indirect effect by activating 1-alpha hydroxylase enzyme, increasing the levels of 1-alpha hydroxylase enzyme, which plays a critical role in conversion of 25-hydroxyvitamin D, the inactive form, to 1,25-dihydroxyvitamin D, the active form of or calcitriol, which then plays a role in increasing calcium absorption from the gut. So PTH acts through the bones, through the kidneys, and then directly through the gut to increase blood calcium levels. Now, upper limit of normal, there is an inhibition of parathyroid hormone release, and importantly, there's an increase in calcitonin release from the parafollicular C cells of the thyroid. This calcitonin then acts on the bone to inhibit resorption and reduce calcium levels, and acts at the kidney to increase calcium excretion and reduce calcium levels. These are the three major players when it comes to influencing calcium levels. Now, when something influences calcium level, it also has an influence on the phosphate level as well. And if you look at the influences of these three hormones, increase in levels of PTH lead to increase in calcium, and at the same time, it usually leads to a decrease in phosphate, because increased PTH has a phosphaturic effect. It leads to excretion of phosphate in the urine. Increase in active form of vitamin D3 increases calcium as well as phosphate absorption from the gut, and to some extent increases calcium and phosphate mobilization from the bone as well. Calcitonin, by acting at the level of the bone and the kidneys, they reduce the levels of both calcium as well as phosphate in the human system. So these are the three major players, and their effects on calcium and phosphate are something which we need to keep in mind when we are evaluating patients with either hyper or hypocalcemia or hyperphosphatemia or hypophosphatemia. Now, as I said initially, the moment we talk of calcium, the skeleton comes to our mind, and that is indeed where 90% of all calcium lies. However, we are not very interested in this 98% of calcium. We are more interested in 2% of calcium, which lies beyond the skeleton, because this is the calcium which is going to influence the function of several cells across the human system. Of this 2% calcium, roughly about 50% is free calcium, which again is the specific calcium with which we are most interested. Now, when we measure serum calcium, what we get is a combination of this free calcium as well as calcium bound to proteins, mostly albumin, but to some extent globulin as well as other anions as well. Now, there might be situations where this calcium bound to proteins, because of alteration in the level of these proteins, might be altered and give falsely high or falsely low calcium levels. I'll give you certain examples. For example, if there is hyperalbuminemia due to dehydration or hemoconcentration, that can falsely increase this bound calcium level and lead to a false increase in total calcium level, or so-called pseudo hypercalcemia. The same can also happen with very high globulin levels, as seen in multiple myeloma, where increase in bound calcium leads to a false increase in total calcium, or pseudo hypercalcemia. On the other hand, a decrease in albumin levels, hypoalbuminuria, either due to malnutrition or liver disease or kidney disease, could lead to a false normalization of calcium when actually the ionic calcium might be high. The patient might have true increase in ionic calcium or true hypercalcemia, but because of low albumin, we are getting to see normocalcemia when we are measuring the total calcium. So of course, the best way to measure calcium would be to measure ionic calcium or free calcium. And the best way to do it would be in the fasting state, because dietary calcium can immediately influence serum calcium measurements. And the best way to measure serum calcium is without using a tourniquet, without venous occlusion, because with venous occlusion, there might be an increase in binding proteins in the local site, which might increase the total calcium levels by as much as 1.2 milligrams per deciliter. So in a fasting state, without a tourniquet, preferably a repeat measurement of total calcium or ionic calcium should be done before labeling that the patient has hypercalcemia. However, we know that we work in setups which are varied in terms of their logistic support. All of us might not have access to this ionic calcium. So what would be the way out? The way out would be to correct for changes in the level of albumin and get a value which is known as corrected serum albumin. I think all of you are aware of this. We know that taking 4 as the normal albumin, for an increase or decrease in the albumin level by 1 above or below this 4, we alter the serum calcium by 0.8 milligrams per deciliter. I'll give you an example. For example, if the measured calcium is 12 and the concomitant albumin concentration is 2 milligrams per deciliter, you remove 2 from 4, you get 2. You multiply it by 0.8, you get a value of 1.6, and you add this to calcium for the calcium correction. So the corrected serum calcium becomes 13.6 milligrams per deciliter. So if your serum albumin is lower than 4, after correction, the total calcium level goes up. If your serum albumin is higher than 4, after correction, your corrected total calcium level goes down. Now again, this is not the best method, because this is a mere approximation, and there are several studies which have shown that corrected total calcium might not always correlate with the ionic calcium, but in setups where you do not have ionic calcium, corrected serum calcium is the best way to go about it. Even in setups where you have ionic calcium, you need to be cautious, because in the presence of metabolic acidosis, there might be a false increase in ionic calcium. In the presence of metabolic alkalosis, there might be a false decrease in ionic calcium. So possibly the best way, if you were to ask one best way of measuring serum calcium, it would be measurement of ionic calcium in a fasting state without venous occlusion, with a concomitant measurement of the ABG to look at the presence or absence of metabolic acidosis or alkalosis, so that we get a true picture of calcium and can label the patient with confidence that yes, this patient has hypercalcemia. Now, once we label that the patient has hypercalcemia, we can divide these patients into 3 different categories: mild hypercalcemia with levels less than 12 milligrams per deciliter, moderate hypercalcemia with levels between 12 to 14 milligrams per deciliter, and severe hypercalcemia, or in some cases, the so-called hypercalcemic crisis, as Professor Sengupta was alluding to, with calcium levels more than 14 milligrams per deciliter. Now, this again could give us a rough guide of the underlying etiology, because if you look at the underlying etiology of hypercalcemia, the possibly commonest cause of hypercalcemia in outpatients, after you've labeled that yes, this patient has true hypercalcemia, is an increase in PTH levels in about 9% of patients with true hypercalcemia. It is hyperparathyroidism, an increase in PTH, which is to blame for hypercalcemia. And usually these patients have mild to moderate hypercalcemia. So the levels are usually about 12 to 13 or 14 milligrams per deciliter, not exceeding that. But in long-standing hyperparathyroidism, the levels could slowly creep up even above 14 milligrams per deciliter. In patients, the commonest cause is, however, malignancy. So if you have an inpatient, sick patient, cachectic patient referral for increased calcium, 50 to 60% of these patients might have malignancy. And these patients again have moderate to severe forms of hypercalcemia, higher degrees of serum calcium. Now, genetic causes of hypercalcemia refers mostly, there are several rare causes of hypercalcemia, like say Williams syndrome or Jansen's metaphyseal chondrodysplasia, which I won't venture into. Among the common genetic causes of hypercalcemia, we have the so-called familial hypocalciuric hypercalcemia, where there is a defect in the calcium sensing receptor. So it doesn't sense calcium well, PTH level is slightly increased, there is decrease in calcium excretion in the urine, and mild elevation in the serum calcium levels, the so-called familial hypercalciuric hypercalcemia, where there is a defect in the calcium sensing receptor. Of course, there are certain other causes, genetic causes, which are associated with hyperthyroidism, like MEN1 syndrome, MEN2A syndrome, and a host of other syndromes where hyperparathyroidism is associated with hypercalcemia, and certain genetic defects are there. Now, vitamin D intoxication is something which we don't see very commonly. When levels of vitamin D in the serum exceed 150 nanograms per ml, it could lead to hypercalcemia. When we use cholecalciferol, high levels of cholecalciferol in the body are metabolized by the 24-hydroxylase enzyme, inactivated to 24,25-dihydroxycholecalciferol, because of which even when you give an individual high levels of cholecalciferol, the risk of intoxication is not that high because the body has its own regulatory mechanisms. On the other hand, if you give an individual calcitriol, 125-dihydroxycholecalciferol, the risk of intoxication and hypercalcemia is more because it bypasses the body's regulatory mechanism. Coming to endocrine, other endocrine causes of hypercalcemia beyond PTH, it could be hyperthyroidism. Particularly in the elderly, there could be apathetic hyperthyroidism, and you have to have a strong index of suspicion if you do not get any other cause of hypercalcemia in an elderly. Other endocrine causes include acromegaly, include pheochromocytoma, and include adrenal insufficiency, where the presentation is a bit more obvious, bit more overt when there is hypercalcemia. Among common medicines which can cause hypercalcemia, we have thiazide diuretics, which increase calcium absorption from the renal tubules. We have lithium, which again alters the set point of the calcium sensing receptor, causes a sort of resistance to the calcium sensing receptor to detection of calcium, leads to a slightly increase in PTH, can lead to gland hyperplasia, parathyroid gland hyperplasia, and is reversible over a period of months. So thiazides, lithium, and the third culprit medicine would possibly be theophylline, which increases resorption of calcium from the bone. Less commonly, teriparatide might also lead to hypercalcemia in certain individuals. What is the clinical presentation of hypercalcemia? How does it present? Although we were taught classically that hypercalcemia presents with stones in the kidney, bone pain, moan because of pain in the abdomen, and groans because of central nervous system symptoms, most of the patients, and I repeat, most of the patients that you get with hypercalcemia in your day-to-day practice will have milder forms of hypercalcemia and won't have any of these symptoms. They would mostly be asymptomatic, because we are picking them early by doing routine calcium in our chemistry analyzers. However, with increasing severity of hypercalcemia, the symptoms could vary. For example, if you look at the kidney, there could be polyuria, nephrolithiasis, nephrocalcinosis, distal renal tubular acidosis, nephrogenic diabetes insipidus, and even acute renal failure or chronic renal failure as a result of hypercalcemia. Coming to the gut, there could be nausea, anorexia, constipation, and even pancreatitis in the rare patient because of hypercalcemia. In the skeleton, of course, we know that it leads to osteoporosis, it leads to increased risk of fractures. And when we consider hyperparathyroidism as the cause of hypercalcemia, it predominantly affects the cortical bone. That is, it predominantly leads to forearm fractures rather than leading to vertebral fractures, which is predominantly trabecular bone. When it comes to the central nervous system, it can lead to confusion, fatigue, and it could even result in coma and death in severe cases. In the cardiovascular system as well, it leads to QT shortening, it leads to bradycardia. It might falsely mimic a myocardial infarction by causing an upward slanting of the ST segment. And it leads to, in severe cases, it leads to the appearance of J waves in what is also called Osborne waves in the ECG. Now, having looked at how to determine true hypercalcemia, the causes behind hypercalcemia, what are the clinical clues which can help us pinpoint as to what is the reason behind hypercalcemia? Now, most of the primary hyperparathyroidism that we are going to get will occur more in women than in men, and it will mostly occur in the 5th, 6th, and the 7th decades of life. As I said, they would mostly be asymptomatic. Some of them would have symptoms depending on the degree of hypercalcemia. And rarely, very rarely, you can get it in younger individuals, but it never is seen. Primary hyperparathyroidism per se is almost never seen in individuals less than 15 years of age. As I said, there could be certain genetic causes of hyperparathyroidism. The MEN1 syndrome, where you can look for other clues like the presence of prolactinomas or the presence of gastrinomas. It could be a part of MEN2A syndrome with associated medullary thyroid cancer or pheochromocytoma. And there are other rarer syndromes like the hyperparathyroidism jaw tumor syndrome, familial hyperparathyroidism syndrome, and so on and so forth. Now, as I said, in 50 to 60% of ill patients, inpatients in the hospital, hypercalcemia is because of malignancy. And when it comes to malignancy, mostly the malignancy is obvious, because it is said that when you get hypercalcemia in a patient with malignancy, the usual survival, the median survival of these patients is usually only a couple of months. So only in advanced stages of malignancy, you usually get hypercalcemia. In malignancy again, this hypercalcemia could be because of parathyroid hormone-related peptide, the so-called PTHrP, which mimics the action of parathyroid throughout the system. It could be because of a metastasis to the bone and local activation of osteoclasts, or it could be even because of local activation in the bone of 1-alpha hydroxylase or local release in the bone of parathyroid hormone releasing peptide. But the important fact is that when you are dealing with malignancy and hypercalcemia, there is usually going to be overt malignancy. It's going to be very obvious. And the commonest malignancies which lead to hypercalcemia are cancers of the lung, cancers of the breast, renal cell cancer, and multiple myeloma. So if the patient is not that symptomatic and you are thinking of a cancer, these are the sites where you first need to search for cancer. Coming to review of diet and medications, as I said, when we are talking of vitamin D intoxication, calcitriol is a commoner culprit than cholecalciferol. Lithium, thiazide diuretics, theophylline, teriparatide can lead to hypercalcemia. Past records showing hypercalcemia is particularly important in an individual who is otherwise asymptomatic. The familial hypocalciuric hypercalcemia that I was discussing is usually present from birth because it's a genetic, it's an autosomal dominant disease. If you get reports during their infancy, during their early childhood, during their adolescence, showing the presence of hypercalcemia, which persists into adulthood, but is otherwise asymptomatic, you must have a very strong suspicion of familial hypocalciuric hypercalcemia, particularly if there is a first degree relative who is affected with the same. So a positive family history, early onset hypercalcemia, mild hypercalcemia, apparently asymptomatic, often leads to a strong suspicion of familial hypocalciuric hypercalcemia. Now, after you have looked at your patient clinically, the single most important investigation that next needs to be done is measurement of a parathyroid hormone level. Now, you need to be aware that parathormone is a peptide hormone. It is heat labile. So you need to collect the sample and subject it to cold centrifugation, not the usual centrifugation, and analyze it as quickly as possible, because otherwise there might be degradation of parathormone and you might get a falsely low level. So it's always preferable to send the person directly to the laboratory which is measuring parathyroid hormone. In case you don't have access to a laboratory, after drawing the sample, you immediately preserve it in a vacuum flask surrounded with ice cold water or ice packs, so that there is no degradation of parathyroid hormone. This needs to be kept in mind to avoid getting a falsely low value. Now, once you have reliably assayed parathyroid hormone, you can get 2 or 3 different scenarios. If you get overtly high levels of parathyroid hormone, say levels above 65 to 70 milligrams per deciliter, you can say with definitiveness that this is PTH dependent hypercalcemia. And amongst the common causes of PTH dependent hypercalcemia, the commonest, again, 90 to 95% of cases would be hyperparathyroidism. Small number of individuals would have the syndrome of familial hypocalciuric hypercalcemia, as I was discussing. And these individuals usually have mild elevation in PTH. They would be in the range of, say, 65 to 70 or at the most 80-85 milligrams per deciliter. Very high levels definitely pinpoint towards primary hyperparathyroidism. Lithium, again, as I said, it alters the set point of the calcium sensing receptor, but it's usually associated with mild to moderate elevations of PTH, not very high levels of PTH. On the other hand, if you get a PTH value which is less than 20 to 25, in that case, you can be very assured that this is non-PTH dependent hypercalcemia or PTH independent hypercalcemia, where you can have a variety of causes like malignancy, vitamin D intoxication, or granulomatous disease, which I'll come to discuss very soon. However, there would be individuals who have a parathyroid hormone level which hovers between mid-normal to the upper range of normal. Now, these individuals could either have hyperparathyroidism or they could have familial hypocalciuric hypercalcemia, and I'll come to this discussion soon. So very high PTH levels, hyperparathyroidism, high normal to slightly normal levels, hyperparathyroidism, lithium, familial hypocalciuric hypercalcemia. PTH levels in the upper half of normal, we think of either hyperparathyroidism or familial hypocalciuric hypercalcemia, and PTH level which are outright low, less than 20, in that cases, we think of PTH independent hypercalcemia. Now, as I said, if your levels are in the upper half of normal or just above normal, the two important differentials which we need to keep in mind are primary hyperparathyroidism and familial hypocalciuric hypercalcemia. Lithium could also be there, but again, lithium would have an obvious history where you would have a history of lithium intake, which you stop and wait for a few months for calcium to normalize. Now, the next step to differentiate between primary hyperparathyroidism and familial hypocalciuric hypercalcemia would be measurement of a 24-hour urine calcium excretion. And it's important that when you are measuring a 24-hour urine calcium, you also measure the 24-hour urine creatinine, because that will help you derive the so-called calcium creatinine ratio. The absolute excretion of urine calcium, if it exceeds more than 200 milligrams in a 24-hour period, or if the calcium creatinine ratio is more than 0.02, to get the calcium creatinine ratio, you can use ready-made calculators. It is the calcium in urine divided by calcium in plasma. The entire thing is divided by creatinine in urine by creatinine in plasma, and you can use ready-made calculators. So if the ratio is more than 0.2, or if the absolute excretion is more than 200, it is primary hyperparathyroidism. On the other hand, if the levels are less than 100 milligrams per day, it is most likely to be familial hypocalciuric hypercalcemia. But there's also a possibility that it could be primary hyperparathyroidism with concomitant vitamin D deficiency and low calcium intake, because of which enough calcium is not getting out through the urine. So in these cases, you can measure the 25-hydroxy vitamin D level, which, if normal, tells you that this is familial hypocalciuric hypercalcemia, where the patient is not excreting adequate calcium in urine, leading to an elevation in serum calcium levels. On the other hand, if the 25-hydroxy vitamin D levels are low, then supplement vitamin D, wait for the levels to normalize, and then recheck the urinary calcium. If the urinary calcium is still low, then it points towards familial hypocalciuric hypercalcemia. Now, levels of urine calcium between 100 to 200 milligram per day and the calcium creatinine ratio between 0.0 to 0.01 to 0.02 fall in the gray zone, where the patients could have either familial hypocalciuric hypercalcemia or primary hyperparathyroidism with low vitamin D levels and low calcium intake. And again, you need to have a look at the vitamin D and replace if necessary before labeling the patient to have either of these conditions. Now, today we have access to clinical exome sequencing, whole exome sequencing, for about 15 to 17,000 rupees cost per patient, which, if there is a high clinical suspicion, can help pinpoint whether there is a mutation in the calcium sensing receptor and whether if the patient has familial hypocalciuric hypercalcemia. Now, we dealt with overtly high parathormone levels. We dealt with slightly high to high normal parathyroid hormone levels. Now, what about the low parathyroid hormone levels? In these patients, if you have high levels of PTH-RP or parathyroid hormone-related peptide, these patients have an underlying malignancy, again, commonly either that of the lung, the breast, the kidneys, or multiple myeloma, as I discussed earlier. However, for all practical purposes, PTH-RP is usually not required to be measured because, as I said, most of these malignancies will be quite obvious. They will be quite overt, because of which even in the best Western centers, they do not have ready access to parathyroid hormone-related peptide measurement, because it is usually not required because of the obviousness of the underlying malignancy. However, if the malignancy is occult and if you do not get any other cause of the PTH being low in the face of hypercalcemia, you must do a PTH-RP level. High levels of 25-hydroxy vitamin D would obviously point towards increased cholecalciferol use or toxic levels of cholecalciferol in the system. Increase in the active form of vitamin D, 125 dihydroxy vitamin D, points towards calcitriol overuse, but it could also be a part of lymphoma or a variety of granulomatous diseases, including sarcoidosis, tuberculosis, etc., where there's increased activity of 1-alpha hydroxylase within the granuloma and within activated macrophages. Again, in most of these situations, when you are dealing with a granulomatous disease or a lymphoma with hypercalcemia, there would be significant pulmonary and extrapulmonary involvement, and the disease would be quite obvious. They would mostly be overt, rarely would they be covert if there is hypercalcemia. There could be other causes of multiple myeloma, local osteolysis, increasing calcium levels, vitamin A intoxication, endocrine causes I discussed earlier. Milk alkali syndrome is something which is not very common nowadays. It was seen earlier when patients with gastritis and peptic ulcers used to consume a lot of milk and calcium carbonate at the same time. Immobilization can lead to an increase in calcium levels, but it is usually not seen in the normal adult individual. It might be seen in younger individuals who have high bone turnover. It might be seen in individuals with multiple fractures or underlying Paget's disease of the bone, where there is high bone turnover, where immobilization leads to hypercalcemia. Otherwise, per se, immobilization does not lead to hypercalcemia. Now, in the earlier part, we had discussed that if you have low urine calcium excretion over 24 hours, less than 100 milligrams per day, it is usually familial hypocalciuric hypercalcemia. However, there are two other situations when you can get low urine calcium excretion in the face of high or high normal serum calcium levels. One of which is the milk alkali syndrome, where underlying metabolic alkalosis leads to increased reabsorption of calcium from the renal tubules. And the other, of course, would be the use of thiazide diuretics, which increase renal absorption of calcium, which is the primary mechanism of them causing hypercalcemia. Other test which might be helpful would be measurement of a serum phosphate level. Now, as we discussed in the beginning, increase in levels of parathormone, they increase calcium levels and they decrease phosphate levels. So if you have low phosphate levels with high calcium levels, you have to keep in mind that there could be an underlying increase in parathormone levels or an increase in parathyroid hormone related peptide, as can be seen with underlying malignancy. However, it is important to remember that only about 1/4 or 25% of patients with parathyroidism, hyperparathyroidism, have a decrease in serum phosphate levels. In others, it is usually low normal, not below the lower limit of normal. So it's more common to get a high calcium level rather than a low phosphate level in individuals with hyperparathyroidism. In familial hypocalciuric hypercalcemia, the phosphate levels may be low. They may even be low normal. So they might be across the spectrum. On the other hand, if the phosphate level is elevated, it usually means that increase in the calcium level and the phosphate level is occurring mainly from the bone, because it's only from the bone that you mobilize calcium as well as phosphate. Calcium phosphate and calcium hydroxyapatite being the predominant minerals present in the bone. In situations where there's an increase in 1-alpha hydroxylase or vitamin D, immobilization, thyrotoxicosis, bone metastasis, where the predominant cause of increase in calcium is because of bone resorption, are the situations where serum phosphate levels are elevated. These are situations where kidney doesn't have a major role to play behind hypercalcemia. There could be some other tests which might be useful as well. They are mainly adjunctive tests, supportive tests, rather than the primary tests. An elevation in serum chloride level with the presence of mild acidosis could support primary hyperparathyroidism. The reverse, that is a lowering of serum chloride and metabolic alkalosis, hints towards milk alkali syndrome, which anyway is not very common nowadays. Now, if you do a skeletal survey, there could be certain telltale features of hyperparathyroidism. For example, we could get the pepper pot appearance of the skull, the resorption of the distal end of the clavicles, the resorption of the radial side of the distal and middle phalanx of the hands, and of course, the less common but almost distinct feature of osteitis fibrosa cystica or bone cysts, which is found in only 5% of patients with hyperparathyroidism, but it could clinch the diagnosis without the need for additional investigations towards presence of hyperparathyroidism. Something which is even less common but very distinctive of hyperparathyroidism is the so-called band keratopathy, where you could get a distinct opacity in front of the cornea. So osteitis fibrosa cystica, band keratopathy, per se, these are not very common, but when you get these findings, you can be quite assured that you are dealing with primary hyperparathyroidism. Now, the moment you know that you are dealing with primary hyperparathyroidism, high calcium, increased urinary calcium excretion, low phosphate, high levels of PTH, the next step would obviously be localization of the lesion in the parathyroid, because in many of these cases, surgery would be curative for life. Now, the two investigations which usually help us in imaging, in localizing the lesion, are a technetium sestami B scan, which you can see to the left of your screen, where in the initial phase, there is an uptake which persists even in the delayed imaging phase. So if there's a thyroid lesion, they could take up the sestami B early, but it's usually washed out compared to a parathyroid lesion with even in delayed imaging, there is presence of uptake because of increased mitochondrial activity in the parathyroid glands. Now, in combination with CT, technetium sestami B imaging, modern technetium sestami B imaging has a sensitivity of around 80 to 90%. This is a SPECT CT localization, and this is a planar 2D technetium sestami B image. However, this sensitivity mostly implies in patients with a single gland disease. In patients with multi-glandular disease, as can often be seen in younger patients as a part of Men's syndrome, the sensitivity of technetium sestami B, even with SPECT CT, hovers around the 50% mark. You can miss about 50% of the lesions. The other investigation which can help in localizing the lesion would be the good ultrasound, particularly if you can use a high resolution ultrasonography with an experienced sonologist. The typical parathyroid adenoma is oval in shape, it is hypoechoic, it is well defined. And when you do a Doppler imaging, you get to see the characteristic polar vessel sign. This is a vessel which is entering from the pole of this vascular lesion. This is the entire lesion, and this is the vessel entering from the pole of the lesion. In lymph nodes, the vessel usually enters from the side of the lesion. So oval hypoechoic lesions separate from the thyroid with increased vascularity and the polar vessel sign is indicative of a parathyroid adenoma. The problem with ultrasonography is that if you have an ectopic parathyroid adenoma in the mediastinal region, in the superior mediastinum, you could miss it. You cannot look at it with ultrasound. However, you can localize it with technetium sestami. Again, in multi-glandular disease, even after combining ultrasonography and technetium sestami B, you can miss up to 40 to 50% of pathologic lesions. So the next step in patients with multi-glandular disease would be the so-called 4D CT, where the fourth dimension is time, where you look at sort of contrast washout on a CT scan to identify a parathyroid lesion. However, most centers, even in Kolkata, they do not do the 4D CT. We do not have access to 4D CT in Kolkata. So we have to be doing with the technetium sestami B scan and the ultrasound to localize the lesion in patients with hyperparathyroidism. Now I'll briefly take you through the principles of management of hyperparathyroidism. Excuse me. So there are 4 basic principles of management of hyperparathyroidism. The main management is the use of intravenous saline fluid replenishment. Diuresis, as you can see, I have put it in red, is something which was sort of standard of care earlier on. However, it has been pushed to the background recently because of availability of bisphosphonates, which are more potent agents in reducing serum calcium, and because of the fact that diuresis carries with it the risk of hypokalemia and hypomagnesemia, which could lead to deterioration of outcomes. Calcitonin is something which has a role, particularly in acute management of hypercalcemia. I'll come to it soon. Glucocorticoids and denosumab do have a role in certain settings in the management of hypercalcemia. Now, when you set out to manage hypercalcemia, there are two things which you need to keep in mind. One, the degree of hypercalcemia, whether it is mild, moderate, or severe. And two, the acuteness and the presence of symptoms, whether it's a chronic hypercalcemia or whether there is an acute increase in calcium levels and the patient has become symptomatic. So if it is mild hypercalcemia, which is usually asymptomatic, you do not need any emergency treatment. You need to avoid drugs in the patient which can worsen hypercalcemia, like thiazide, lithium, teriparatide, or theophylline. You must avoid immobilization because immobilization leads to increased bone resorption, increased absorption of calcium from the bone. Avoid volume depletion because patients with hypercalcemia are already volume depleted. It is known that if there is calciuria, it concomitantly leads to natriuresis as well. This leads to a decrease in extracellular volume and leads to sort of a pre-renal sort of a syndrome and further leads to increase in calcium levels. So volume depletion should be avoided. You should replete these patients with fluid. They should be asked to drink about at least 6 to 8 glasses of water regularly. And you should avoid high calcium diet, but you must give the daily requirement of calcium, which would be around 600 to 800 milligrams per day. And of course, if you know that there is a specific underlying cause, if you suspect, for example, primary hyperparathyroidism, you need to localize the lesion and treat the underlying cause. With increasing severity, moderate hypercalcemia, you usually do not require treatment if the patient is otherwise asymptomatic. But as I said, if there's an acute rise and if the patient becomes symptomatic, particularly there is altered sensorium, you need to start treatment for hypercalcemia using saline and bisphosphonates, as I'll come to in the next slide. And of course, the same precautions, avoidance of drugs which can precipitate hypercalcemia, avoidance of immobilization, etc., fluid replacement is something which needs to be done in all cases. However, the tricky situation and the difficult situation is actually when we face severe hypercalcemia levels more than 14 milligrams per deciliter, particularly when the patient is asymptomatic. What do you do in these settings? Now, the mainstay of therapy in these settings is fluid replacement. You replace normal saline. The fluid which you use is normal saline. You start at a rate of 200 to 300 milliliters per hour, and then you gradually reduce the rate to maintain the urine output at around 100 to 150 milliliters per hour. Calcitonin is something which has a role to play in the acute phase of illness. It can be given in a dose of 4 to 8 international units per kg, twice daily to 4 times daily. When you are using calcitonin, after giving the first dose of calcitonin, look at the change in calcium after 6 hours, because there would be patients who are calcitonin sensitive, there would be patients who are calcitonin insensitive. So only if someone is calcitonin sensitive, you go on giving calcitonin for the first 24 to 48 hours. Why not beyond 48 hours? Because it has been seen that tachyphylaxis occurs to the action of calcitonin after 48 hours. So it's not going to be effective beyond 48 hours. It is important to keep in mind that intranasal calcitonin has no role to play in the management of hypercalcemia. It might have a role to play in pain reduction in vertebral fractures, but has no role in hypercalcemia. You have to use subcutaneous or intramuscular calcitonin in the management of hypercalcemia. Now, calcitonin acts within hours, and if you give normal saline and calcitonin, as has been indicated, in most individuals, there's a decrease in serum calcium. It comes down within the normal range within the first 12 to 48 hours. However, at the same time, in patients with severe hypercalcemia, you need to give zoledronic acid as well, because of the fact that after the first 2 days, the effect of calcitonin is going to wear off. And once you give zoledronic acid, it starts acting within 2 to 4 days. So it takes over the role of calcitonin and prevents a recurrence of hypercalcemia. Zoledronic acid, the dose that we classically use in osteoporosis management is 5 milligrams. However, the dose that is indicated as per label in management of hypercalcemia is 4 milligrams, which needs to be given slowly over 15 minutes. Now, we know that in patients with compromised renal function, zoledronic acid cannot be given. However, there are trials in hypercalcemia of malignancy where zoledronic acid has been given even up to a creatinine level of 4.5 milligrams per deciliter. But having said that, in those with an estimated GFR of less than 30, one should be very cautious when using zoledronate, could try to avoid using zoledronate. And if it needs to be given, it needs to be given with adequate hydration and slowly over an hour, instead of giving it over 15 minutes as you would otherwise do in patients with better renal function. Now, the paradox here is that if you give bisphosphonates, you reduce calcium levels, which could in turn lead to improvement in renal function by preventing the so-called pre-renal part of the renal failure syndrome. However, as I said, you need to make a balance here between the renal function and between improvement in calcium levels. Now, there is data also with the use of pamidronate to reduce hypercalcemia. However, it's not easily available. It needs to be given over 2 hours, more cumbersome, and its efficacy is lower than that of zoledronic acid in the management of hypercalcemia, because of which it has gone out of favor. As I said, in select settings, you can use denosumab in the management of hypercalcemia. Where do you use denosumab? You use it in those with severe renal impairment, eGFR less than 30 or less than 20, where you cannot use zoledronic acid, or in those in whom you have given bisphosphonate, but the patient is not responding to bisphosphonate. Now, denosumab acts even more slowly. It takes its effect, kicks in a median of about 9 days, and it's usually given in a dose of 60 to 120 milligrams subcutaneously. Now, zoledronic acid can be repeated at the earliest at 7 to 14 days interval if the calcium is not coming down. With denosumab, there's a study which used it initially weekly and then monthly till the calcium levels came down. That zoledronic acid is long-acting. Its effect persists for at least around 30 days. Denosumab is even longer acting. Its effect persists for around 3.5 months. However, when you are using denosumab, you need to be careful because it can lead to prolonged hypocalcemia as well. And there are individuals who have required IV calcium after administration of denosumab. Now, when we talk of loop diuretics, as I said, it is not a routine standard of care now. You use it only in patients with concomitant heart failure or concomitant renal failure, not in every patient coming to you with hypercalcemia. You use it with saline hydration in certain settings where there's a risk of volume overload. Hemodialysis has a role, particularly in patients with very high calcium levels, 80 to 20 milligrams per deciliter, with neurologic symptom, which is usually seen in associated malignancy. In severe heart or renal failure, where you cannot give fluid repletion, you can use hemodialysis to reduce calcium levels. Now, in patients with normal renal function, when you are using a low calcium dialysate, it could also lead to hypophosphatemia. So in those with low phosphate levels and normal renal function and high calcium levels, when you are using hemodialysis, you can use a phosphate-rich dialysate to avoid hypophosphatemia. Glucocorticoids have a role to play, particularly when there is increased 1-alpha hydroxylase activity, as seen in granulomatous diseases, lymphoma, and as seen with vitamin D intoxication. And 20 to 40 milligrams per day reduces calcium levels in 2 to 5 days. Cinacalcet is a drug which increases the sensitivity of the calcium sensing receptor to calcium. It's a calcimimetic. It has a role to play in patients with parathyroid carcinoma, which is inoperable, where you cannot do anything else. in secondary hyperparathyroidism in patients with renal failure, and in certain patients with familial hypocalciuric hypercalcemia. As I said, familial hypocalciuric hypercalcemia is usually asymptomatic. However, there are case reports of chondrocalcinosis and pancreatitis occurring in familial hypocalciuric hypercalcemia, the rare patient, where you could use sinacalcet. Monoclonal antibodies against parathyroid hormone-related peptide is something which is state of the art, which is yet to be available on a commercial basis. And of course, we have the older agents, calcium nitrate, mithramycin, which are no longer used because of toxicity. Phosphate might have a role to play in patients with very low phosphate levels and concomitant hypercalcemia. You can give oral or IV phosphate or phosphate enema to reduce calcium levels. A brief mention of specific management of hyperparathyroidism. After localization, of course, you need to go for surgery. It is often said that the surgeon's hand is the best localizing instrument. Even when your localizing fails, using ultrasonography or sestamibi scan, a good surgeon might localize the lesion during surgery and take out a single parathyroid adenoma. In younger patients, less than 45 years old with hyperparathyroidism, you need to search for genetic syndromes like MEN1, MEN2A, as I discussed earlier. And in every patient with hyperparathyroidism, you need to look for osteoporosis, particularly the distal third of the forearm. You need to have a look at the cortical bone to see whether there is osteoporosis or not. Now, after the parathyroid lesion is removed, you can get what is called the hungry bone syndrome. So your patients who are going to undergo a surgery for parathyroidism should have adequate levels of vitamin D before the surgery and should be given calcium and calcitriol immediately post-surgery. The calcitriol can gradually be weaned off, but calcium is usually given up to 1 year after surgery because the bone formation, bone accrual occurs up to 1 year after surgery after hyperparathyroidism management. Now, we know that there are certain specific indications for removing a parathyroid adenoma. We learned about specific EGFR cutoffs, presence of stones, osteoporosis, etc., etc. In the recent past, interest is growing in the cardiovascular risk and increased risk of other malignancies associated with hyperparathyroidism. So we might get additional indications where possibly every patient with hyperparathyroidism will need to undergo surgical management. This is my final slide for the day. Just to sum up, when you get a patient with hypercalcemia, you first need to identify whether this is true hypercalcemia or pseudo hypercalcemia. Now, after you have done that, you look for obvious clinical features. In most of your cases, obvious clinical features might not be there unless you are dealing with hypercalcemia of malignancy, where the disease would have been in a quite advanced stage when the individual comes to you. The first and the most important investigation would be a parathyroid hormone level. You need to keep in mind that this is a heat labile hormone. If you have high levels of parathyroid hormone, overtly high levels, you are dealing with hyperparathyroidism. If you have high normal to slightly high levels, it could either be hyperparathyroidism or familial hypocalciuric hypercalcemia, where a 24-hour urine calcium could be helpful, as could be a genetic analysis. If you have low PTH levels, if the malignancy is obvious, you do not need to go for PTH-RP. If it is occult malignancy, as might occur rarely, you need to find a laboratory which does PTH-RP. With normal PTH-RP levels, or even otherwise, you look for 125 dihydroxy levels, which if high could point to calcitriol intoxication or the presence of granulomatous diseases or lymphomas, and which if low points towards other endocrine causes, vitamin A intoxication, and other rarer causes of hypercalcemia. I enjoyed being a part of this lecture. I hope I have not bored you with very prolonged discussion. If there are questions, we'll try to take them up now.
Yeah, thank you, Dr. Goswami, for a very rather comprehensive overview of hypercalcemic disorders and with practical tidbits put in. There have been quite a few questions to start with, and I also invite other questions. First one from an anonymous attendee. Now, when you are estimating 24-hour urinary calcium. So what dietary restrictions, if at any, you need to do? That's one question. And I would ask, how exactly would you go for interpreting a 24-hour urinary calcium excretion report, adequacy of collection, so on and so forth, because these are practical questions.
Yes, it is a very important question, because if you have low calcium in your diet, it could falsely lower the 24-hour urine calcium level. So you need normal dietary calcium, which is around 800 milligrams per day for most individuals. So you should ensure adequate dietary calcium intake, mostly in the form of milk products, pulses, and green vegetables. So it would be around 800 milligrams per day for most individuals. The second part, which is very important, is adequacy of collection. As I said, we need to do a urine creatinine, 24 hours urine creatinine along with, to ensure adequacy of collection. It not only ensures adequacy of collection, but also helps us determine the calcium creatinine ratio. As a rule of thumb, it is usually said levels above 1000 milligrams per day are seen in women, and more than 1400 to 1500 milligrams per day of creatinine are seen in males, on an average Indian male. So creatinine helps both in determining adequacy of collection, urinary creatinine, as well as in determining the calcium creatinine ratio. Now, with regard to dietary calcium, I'll just give you another interesting tidbit as well. It has been seen that in patients with high normal PTH level with underlying hyperparathyroidism, some of them might be taking a high calcium diet for some reason. They might be on calcium supplements, as often happens in several postmenopausal individuals. Now, when you stop these calcium supplements, you bring back the calcium intake to normal physiological levels, the PTH might shoot up. So in high normal PTH level, if you're suspecting hyperparathyroidism, if the patient is on additional calcium supplement, you can stop that and redo the PTH to see if it is going up.
Right. So there are a couple of questions from Dr. Shivendu Ghosh himself. Whether AKI due to hypercalcemia is reversible?
Yes, it is reversible. Correction of calcium as well as fluid hydration results in
dehydration, but many a time a chronic kidney disease itself may be a cause of hypercalcemia, chronic or acute on chronic, that we have to keep in mind. Whether zoledronic acid is useful in multiple myeloma with hypercalcemia. So that brings us to the humoral hypercalcemia of malignancy. So we have talked about glucocorticoids, and I do appreciate that in the granulomatous diseases, as I have rightly pointed out, and in cytokine-induced hypercalcemia, actually glucocorticoids are going to act. But when it is PTH dependent or PTH RP dependent, then of course glucocorticoids are not going to act. This has to be kept in mind, because you cannot just treat it as a blanket humoral hypercalcemia of malignancy. So now zoledronic acid in multiple myeloma.
So zoledronic acid, the mechanism of action of a bisphosphonate is inhibition of resorption of calcium from the bone. And in multiple myeloma, directly or indirectly, most of the calcium is going to come from the bone. So it does have a role, particularly if the hypercalcemia levels are severe. The specific area where bisphosphonate does not have a role in hypercalcemia is milk alkali syndrome, where the bone doesn't have a predominant role to play. And there it has been seen that if you use bisphosphonate, there is definitely going to be hypocalcemia. So other than milk alkali syndrome, in most other causes of hypercalcemia, bisphosphonates have a role to play.
Yeah, again, on a mechanistic basis, when we consider using denosumab, is it effective in all causes of hypercalcemia, or in what are the causes of hypercalcemia it's more effective?
Yes, so denosumab again inhibits resorption of calcium from the bone. So for example, in patients with familial hypocalciuric hypercalcemia, where the bone has no role to play, or in patients who are on a thiazide diuretic, where the bone has no role to play, we won't be using it. Only in patients where the source of increased calcium is bone resorption, denosumab will have a definite role to play. And it's not an alternative for bisphosphonate in all patients, only in patients with poor renal function, only in patients who are refractory to bisphosphonates. We use denosumab, the caveat again being that prolonged hypocalcemia may occur when you use denosumab. So you need to be careful on that count as well.
Now, severe hypocalcemia, there is sort of hungry bone syndrome after parathyroidectomy. So, means what are the causes? First, for the residents, for the students, what may be the causes of hypocalcemia, whether transient or prolonged after parathyroidectomy for any parathyroid disorder?
So there would be two predominant causes. One would, of course, be the hungry bone syndrome, where there was increased bone resorption for so long. Now the bone wants to reclaim its calcium. It takes up calcium from the extracellular fluid. The other would be the absence of 1-alpha activation, because PTH plays a predominant role in activating 1-alpha hydroxylase enzyme. So there would be absence of active forms of vitamin D, because of which I said in the immediate post-op period, you need to give calcitriol along with calcium, not cholecalciferol along with calcium. You can gradually wean away the calcitriol, but continue calcium at least for 1 year, because that is the duration during which accrual of bone might take place after correction of hyperparathyroidism.
Right. And if it is a permanent one, so when do you foresee a permanent hypoparathyroidism following parathyroidectomy? Because in some situations of hyperparathyroidism, especially multiple gland hyperplasia, we need to go for say 3.5 or implant to the forearm and so on, and many a time that may not work out. So that may be at times cannot be an unavoidable complication.
So we suspect permanent hypoparathyroidism or iatrogenic hypoparathyroidism when you require calcitriol for very long time. Whenever you try to wean the patient of calcitriol, the level of calcium you see it's coming down, or in patients with very high requirements of calcium supplementation, 1.5 to 2 grams per day, whenever you try to reduce the dose of calcium supplements, you find that the serum calcium is coming down. So prolonged calcitriol requirement, high calcium requirement denotes underlying iatrogenic hypoparathyroidism.
Another very practical thing, the market in India at least is flooded with calcium, calcitriol, fixed dose combinations. How do you take at it, and what are the indications of calcitriol in endocrine practice?
So again, I think it's a very important message that cholecalciferol and calcitriol are two different drugs. When you use cholecalciferol, the body converts it into 125 form as per its requirement. And if you give excess of cholecalciferol, the body can metabolize it to 24-25 inactive form and excrete it from the system. So when you're using cholecalciferol, you are using the pre-drug or pro-drug, and the body can convert it to active and inactive forms as per requirement. So the chances of toxicity or the chances of hypercalcemia are low. On the other hand, when you're using calcitriol, the body cannot convert it into an inactive form on its own. It has a short half-life, but during that half-life, if you overdose, the chances of hypercalcemia, the chances of nephrolithiasis, nephrocalcinosis, and possibly even adynamic bone disease by inhibiting PTH levels increase with calcitriol. So for all practical purposes, most patients with vitamin D deficiency require cholecalciferol instead of calcitriol. The few situations where calcitriol has a role, of course, in patients with advanced kidney disease, where the 1-alpha hydroxylase activity is lost, that's a common scenario. In patients, as we discussed, following parathyroid surgery leading to iatrogenic hypoparathyroidism or hypoparathyroidism because of congenital or other causes, calcitriol has a role. And of course, in certain forms of vitamin D resistant rickets, where there is defect in activity of 1-alpha hydroxylase, calcitriol has a role. Other than these few settings, calcitriol does not have a role in the management of vitamin D deficiency.
I think that also answers Dr. Anindita Datta's question. So you had asked the difference between calcitriol and cholecalciferol. Now we have Dr. Shivendu Ghosh again asked, is a very important question. Parathyroid removal in secondary hyperparathyroidism. Actually, that brings us to the issue of tertiary. And if you believe, I don't know whether you believe in the existence of quaternary hyperparathyroidism. So what are they? Means what, at least we believe in tertiary. So
quaternary, possibly there has to be a second or a third hormone influencing parathyroid, which we don't have any hypothalamic control here. So that, or say very low calcitonin levels leading to increase, which we are not aware of. So
it's basically in a setting of chronic kidney disease when there is
turn into tertiary, prolonged secondary leads to local autonomy, and it could lead to hyperplasia or a parathyroid adenoma like situation where there is
actually in some literature the hyperplasia has been described as tertiary and the adenomatous transformation is quaternary, but is generally used as tertiary. So how do you manage that? That's what Dr. Ghosh has asked.
So for secondary hyperparathyroidism, surgery has not been tried. Cinacalcet can be used in certain settings. However, tertiary, if difficult to control, you can opt for surgery. But usually these patients would be very sick patients and poor candidates for surgery with a limited survival lifespan anyway. So it's up to the surgeon whether the surgeon would be agreeable or the anesthetist would be agreeable in these patients.
I think we have had many questions from the panelists. Now, many of the panelists, I see Dr. R.N. Sarkar, Dr. Shivendu Ghosh himself, Professor Partha Karmakar, Dr. Amol Banerjee, all of them, Dr. Shubir Banerjee, all of them are live. I think, sirs, if you can ask any questions or give your comments.
Okay, Chairman, sir, I am Professor M.K. Roy. I have got
to
yeah. So to Soumik is an excellent exposition of a subject. I just want to ask him, what is the hypercalcemic potential of classical thiazide diuretics and that of your chlorthalidone?
Yes, sir. Thank you, sir. I remember learning a lot of my medicine during my postgraduate days from you. So thank you for the question. So thiazide diuretics in general, they cause hypercalcemia by increasing calcium reabsorption from the distal collecting tubule. However, it's usually mild. It is to the range of 1 to 1.5 milligrams per deciliter that they increase the calcium. However, when faced with another cause of underlying hypercalcemia, the increase in calcium could be even more. And it's the thiazide and thiazide-like diuretics, they all have this property of increasing calcium levels, including chlorthalidone.
Dr. Soumik Goswami, I am Dr. Karmakar speaking.
Yes, sir.
Very excellent and lucid way of exposition.
Thank you, sir.
And you have made the subject really very interesting. I think the PGTs will be immensely benefited and they will definitely go through the textbook.
Thank you.
Thank you.
Thank you, sir.
Thank you on behalf of API.
Thank you, sir.
Thank you.
Right. So if there are no other questions, I think it's time for me to give my concluding remarks, especially for the residents out here. Dr. Soumik Goswami has dealt with the issue of hyperparathyroidism in a very elaborate way. You may not get a case for examination or in the MD examination, but there would be crossings in the flying oral or emergency pertaining to hypercalcemia. Now, there are very practical points on hypercalcemia, how to collect blood for calcium estimation, whether you would go for total calcium or ionic calcium, how would you correct for hyper or hypoalbuminemia. These are very common practical issues that we have to face, and you should be very much sound on that. Another thing what Dr. Goswami has pointed out as the classic hypercalcemia or hyperparathyroidism, with stones, moans, groans, and groans vis-a-vis asymptomatic hypercalcemia and asymptomatic hyperparathyroidism. Having said that, this is mainly from the Western literature. Having said that there is this dichotomy, still we have a variance of presentation in India, probably since we do not do multi-channel chemistry as often as we do in the West. In India, we still do get advanced cases presenting either with jaw tumor or pathological fracture. I have alluded to the issue of calcitriol, calcium fixed dose combination. This should not be abused, and calcitriol has some definite indications in endocrinology practice that you have to keep in mind. And CKD MBD, that is metabolic bone disease in CKD, is one area which we should be very much conversant about, because we would be dealing a lot of cases of CKD in general medicine practice, and there the normative value of parathyroid level is different. Whatever Dr. Soumik Goswami has pointed out is 20 to 80 picogram per ml. That will not hold good if the EGFR is 15 or 20. There you have to allow, say, maybe up to 150 to 300 picogram per ml, because if you suppress the parathyroid hormone too much at this stage, you may get adynamic bone disease. And of course, when you are dealing with hypercalcemia, a very good approach is to look for parathyroid dependent and parathyroid independent hyperglycemia. And if you follow that algorithm, the diagnosis becomes easy. And again, when you deal with the humoral hypercalcemia of malignancy, again, you have to differentiate whether that is parathyroid hormone dependent or not, because the treatment, most importantly, the fundamental approach and the fundamental treatment varies. And having said everything, the commonest cause of hypercalcemia, chronic hypercalcemia that we encounter in endocrine practice is due to parathyroid adenoma or hyperplasia, and that can be cured in many of the patients via surgery. Only in cases of advanced malignancy-induced hypercalcemia, we may have to go for palliative management and with a lower patient's life expectancy. So with this, I thank Dr. Soumik Goswami immensely for his very astute dealing of the topic. And I once again congratulate API for continuing these master classes, probably on a weekly or monthly basis, and giving us the platform to deliberate on a very important topic. Over to the API organizers for the closing remarks.
Okay. Now I request Dr. Harishankar Pathak, who is the chairman of API West Bengal branch, to give thanks to both chairperson and the speaker. Harishankar Pathak, please. Harishankar Pathak.
Sir, you are muted.
Sir is muted. Sir is muted, possibly.
You have to unmute yourself. Yeah.
So in one word, I will say that the program has been excellent. It is one of the best master classes which we have organized for the last 1.5 years. The deliberations by Dr. Soumik Goswami has been excellent. It's very clear cut, and I think it's very useful to all our students. I also thank Professor Niranjan Sengupta, who had been a seasoned speaker, seasoned chairperson, and really he was his conduction of the program was excellent. So I thank you everybody, all the participants, all our course directors for this program. Thank you all.